go ahead and start. For those that are away from IMD, I wanted to give you my phone number if you have any questions. 1-673-1848. And Patsy has just an announcement, and then we'll turn the time over to Dr. S. Oh yeah, so those that are listening, if your phone is on hold, please change it to mute. So what I'm going to do is turn this on. Maybe.
All right. I can first step.
I have Sean and have worked at Reg Davis. As you all know, Sean is our manager, Reg is our assistant, and we great managers, and we appreciate all that they do. We don't know all that they do, and we probably don't want to know all that they do, but we appreciate you both very much.
We appreciate your call and patience. Please be assured that your call will be answered shortly. Thank you.
Here, please take your phone off hold.
Okay. Hello. We'll make it. I wish. You wish. So, we had our first small group case study today, and it went well. It was well attended. We had 4 physicians and one of the midwives there, and it was great. So please come, and don't be worried about coming. Scary. It's fun, and it'll go quick. It'll go quickly. Do you guys have any questions before? Being offered IMC nurses, right. So there's a chance to sign up. I think there's 8 more classes that are spread out to the next 3 or 4 weeks. Sign up for, because I will deny this if you say this, but physicians cannot stay for longer than an hour. They're like going to start freaking out and leave. So some of them did. So it won't go longer than an hour. But I'll stick around and answer questions. Do you guys have other questions? Okay, you can sign up for one of these on the sign-up sheets that I think Shauna has, and they'll be available at the board checkouts. Yes?
I went this morning, and it was well worth the hours.
Great.
And it's an amazing experience. I should have wished it should have been happening 10, 15, 20 years ago.
Yeah, don't set the bar too high. The IMDb score was about 5. Some of the critics, it's got Rotten Tomatoes of about 50%, so we're okay. Yeah. So great, thanks for coming and participating. So today I just came up with this topic while I was sitting on an airplane, okay? And I was thinking about what the chances were that I was going to crash, which is not a good thing to think about when you're getting on an airplane. And then I realized, hey, let's talk about the golden hours of fetal heart rate interpretation. So, what is the chance that the airplane that you're sitting on is going to crash? Well, it turns out that there's this rule. I looked it up online. It says it's called the +3 - 8 rule, which means, basically, 80% of all airplane crashes happen within the first 3 minutes of a flight or the last 8 minutes before landing. So if you get through the first 3 minutes, you're probably going to be okay. And if you get through the last 8 minutes, you're on the ground. Everything's happy, okay? The other thing this thing actually said, which I thought was interesting and applies here, is that it's crucial to know where the emergency exits are. And this article that I was reading said the first thing you should do when you come and sit in your seat is count the number of rows to the nearest exit so that you know how to get off if there's a crash. And I thought, well, both of those things probably apply to fetal heart rate interpretation. I found this cool graphic, okay? Maybe hard for you guys to read, but this is fatal accidents and onboard fatalities. Now, I've been called one time when they say, is there a doctor on the plane, right? I was flying back from London to the United States, and I had Flint Porter and Ware Branch sitting with me. And beep, is there a doctor on the plane? And I looked at Flint. We both looked over at Ware, and Ware held up a beer and said, I'm not fit for duty. So of course, Flint and I go over there. There's some like middle-aged man is having indigestion. He's got like heartburn, or maybe he's having a heart attack. And so we said, well, one of you needs to take care of him, and one of you needs to go to the cockpit. And I said, I'll go to the cockpit. So I left Flint there, like trying to figure out, okay, where I put this blood pressure cuff, and and I said, Flint, just give him an aspirin. Have him put an aspirin. Have him take an aspirin quickly. And so I go up to the front, and I'm like in there with the pilots, and they put the little headset on me, you know, with the ear things and okay, we're going to connect you to the emergency room in Pittsburgh. And the guy gets on, like, hey, and he says, is this a doctor? I said, no, this is an obstetrician. I said, I'm 90% sure he's not pregnant. And that's about all. He's got chest pain, and I gave him an aspirin. And they said, well, that's probably a good thing, and we kind of talked through it, but it was kind of funny. Is this a doctor? No, I'm an obstetrician. Okay. And so my neighbors think about me too. So anyway, so the bottom line here is onboard fatalities, right? Those are the ones that people who are sitting there thinking, I wonder if this plane's going to crash and have their heart attack, right? But if you look at it, check this out. There are some people who 10% of accidents happen while they're taxiing the plane to the runway, right? And then 19% of the accidents, from the time they start the engines and they're going down the runway until you get to your altitude where you're flying, 19% of the accidents happen during that time, and 59% of them from the time when we're starting our initial descent. That's when you should start to get worried, because there's a 59% chance. That's when 59%, not 59% chance. Let's see, boy, that would be a lot of airplane crashes. There's 59% of the airplane crashes happen from that time until you're landed. Okay, why? Why do 78% of the airplane crashes happen during these two parts of the flight? They're critical, okay, but when you say critical, why are they critical?
Taking action.
I hear taking action, I hear communication.
There's judgment on the part of the pilot and co-pilot.
There's judgment here, right? I mean, when you get up to that cruising thing, that's when you put it on cruise control, right? Autopilot, and it'll go until you're not out of gas, right? But you don't have. There's really not a lot of judgment when you're cruising, right? So you're having to make decisions. There are things that you're doing. And in fact, not just things. There's a whole bunch of steps that have to happen in a specific order for it to work right, right? And what was the other thing? Communication. This is when communication is critical in these two things. And I was thinking, well, it's usually at a transition from one state to another. Kind of when you're transitioning from one kind of stable state and trying to get to another stable state, that transition phase is where there's really the chance for a problem to happen. Okay? Now, this is the same graph. Okay, are there critical times during labor when the risks of complication are highest? When do you think that is?
Descent and delivery.
So descent, yeah. So we're starting our initial descent. We'll start pushing now. And please do not get out of bed, or please get out of the tub, right? And here it comes. So yeah, during the last hour, right, and during the first hour. So it turns out that if you think about the course of labor going from the onset of labor to delivery, there's a little period where you're in early, before labor starts, when you can have complications that could already, like pregnancy complications like preeclampsia or diabetes or hypertension or growth restriction, that are actually problems with the engine that we just don't know about yet. Okay? So this is the pre-labor state or early labor state. When they get to the hospital at the time of admission, I'm saying, okay, that's like us sitting on the runway and we're revving up the engines, okay? And during that first hour after they get here, it's like takeoff. There are judgment calls that you need to be making. There are tasks that need to be accomplished. There is communication that has to happen. And if you don't think about that first hour as being critical, you're off on the wrong foot. And and the rest of the labor is going to be a problem. Okay? But once you get through that, and if everything is set, then you're on cruise control, right? Ongoing surveillance and monitoring the labor progress when all the things are established. But you're watching for warning lights, right? And one of two things is going to happen. Either they're going to be completely dilated, and now you say, okay, now we're in our descent part of this flight. Or you're going to see changes in the heart rate that tells you something's happening. The engine's sputtering. I think we're going to have to land in the next hour, okay? And then the process from that point to the time that you deliver is critical. Is another key time when communication errors, missing steps, not a poor judgment or problems with judgment are going to result in problems. And then the taxi back to the concourse, right? So neonatal resuscitation, that's the next step that has to happen. So I would propose that these transition times are actually the golden hours of labor and delivery, fetal heart rate interpretation. And you should be thinking about that. In fact, you shouldn't be distracted. Just like pilots, they have a checklist that they go over. They can't be distracted during this time, and they've got to get through those things. And you should be thinking about the first hour and the last hour as the key times when you should be doing things. Now, unfortunately, we don't always know when the last hour is. That's a problem, okay? So I actually sat down and said, and this is coming from a physician, okay? I'm thinking, well, what are the goals that have to be accomplished during the first hour after admission? Okay? And I'm thinking primarily about taking care of this patient with respect to the fetal heart rate monitoring and her labor progress. Okay? So I'm sure that there are more than what I'm saying, and I would encourage you guys to speak up and say, you forgot this or forgot that, because it'll be a better talk the next time you hear it if you give me some input right now, okay? But in my opinion, the first thing on your checklist is make sure you have adequate tracing, okay? Now what I mean by that is that you have tracing that you can actually interpret and that you're tracing the fetus, not the mother, okay? Because if you don't have adequate tracing, you don't know what's going on. It's like the windows in the plane being blacked out or being covered with snow. You've got to clean them off so you can see where you're going, okay? I actually think that there are, these are the key features of adequate tracing. Number one, they're not missing data, okay? How many times do we show a tracing up here where there's 10 or 15 minutes with no data on it, right? And nobody knows what's happening during that time. So try to make sure you have at least 70% or more of the tracing present. It should be sufficient to be able to interpret the tracing. What I mean by that is if you can't determine the baseline, the variability, the presence or absence of accelerations or decelerations, and actually determine the number of contractions that are happening, you don't have an adequate tracing. You can't interpret that, okay? And then there are times when you should be concerned about the possibility that you're tracing the baby instead of the mother. There are three key times that I can think of when it's known that your tracing of the baby may switch to the maternal fetal heart rate. When are those times?
Getting an epidural.
Getting an epidural. So repositioning the patient. When you reposition the patient, sometimes the monitor will pick up the maternal heart rate instead of the fetal heart rate. What else? During descent. So when the baby's coming down or when you're starting to push. Okay? So those are two key times. I was looking at a tracing from another institution where the tracing kind of had these increasing decelerations, and it looked like, okay, we're having recurrent variables, and I think we're going to have to do something. And then all of a sudden, boom, it was reactive, and it looked great. I mean, baseline 120, moderate variability, accelerations. Okay, and This was a case that was actually going to court, and the physician said, I looked at the tracing, and it was textbook reactive. I walked in and saw it, and it was great, and I said, I'm going back to round. And this person left, because the tracing looked great. And every person who walked by looking at the tracing said, this is awesome. But what they didn't realize was, when you went from the tracing where you had the recurrent variables, the mother sat up, was squatting with on a bar, and was pushing in the squatting position. And that changed, literally in less than a minute, that change was when we started monitoring the mother. And you could tell because every time she pushed, there was an acceleration instead of a deceleration. Melody raised a hand. I don't know what that means, but it just came up there, so. Okay, send the text to Chris, and we'll answer that question. So if there's a sudden change, a dramatic change in the way the tracing looks from 1 minute to the next, okay, or if the baseline is lower than you would expect, and it's in the same range as the mother, or if there are accelerations with more than 50% of the contractions, or if you have a prolonged deceleration that goes from a normal baseline and comes down to a baseline that is around where the mother is and never comes back up, you may have switched to the maternal heart rate. And you should make sure so this can be fixed by looking with ultrasound, a pulse ox, or an FSE to confirm as needed, okay? Remember, these are the key pieces that you need to be able to interpret your tracing. If you can't get all of this information, the baseline, the variability, the decelerations, the contractions, the accelerations, and how this is changing over time, then you don't have adequate information to be able to monitor through labor. Okay? Now, after you've figured out that the tracing is adequate, the next thing to do is identify potential risk factors. Okay? I think of risk factors in 3 key categories. Okay? 1, there are the pre-existing risk factors. These are pregnancy complications. These are the things that have been going on before the labor even started. So you should be aware of IUGR, preeclampsia, hypertension, diabetes, group B strep. I would also put up there a previous history of cesarean section. Okay? And I would also, and we'll talk about this in just a minute, but those are history problems. Okay? There are a set of problems that are right now. Okay, so if you're using the airplane analogy again, those are, well, on the last flight or the flight before, we lost cabin pressure at this time, or the engine was making a rattling noise. Those are chronic things that have been going on. When you're ready to take off, if you're revving the engines and you hear a funny sound, or you smell smoke, or something like that, that's an indication of a problem that's acute, that's happening right now. What are the acute symptoms or signs that you should be looking for in the first hour when someone comes to labor and delivery to tell you that there's something acute going on? So, I'm not even talking about the tracing right now. I'm talking about the patient who comes in and says, what are the words that come out of the patient's mouth that make you worry? I'm bleeding. That's huge. That's a huge red flag. That's the same as saying, I smell smoke on the plane. Okay? What else?
I haven't felt the baby nerve.
Decreased fetal movement. That should be a big red flag. And you should treat those patients differently. Okay? I would say, I have a fever.
I have a headache.
Or I have other symptoms that I have a headache, or I've got the chills. Another thing that you want to ask is how long have they actually been in labor, because it may be that they've been laboring for a long time and we're catching them in the middle. Okay? But what I hope you hear and then unusual pain. Okay? Decreased fetal movement is the biggest one. Don't ever blow that off. Okay? Always remember that if there's decreased fetal movement, I need to be worried about that, and I need to figure out what's going on in that first hour. Same with vaginal bleeding. Okay? The other things that you might say, meconium. Okay? That's another thing that might indicate that there's an issue going on. And then I've got the history of other complications, like in previous deliveries, like the C-section and the postpartum hemorrhage. She had a postpartum. When I asked the residents, what is the biggest risk factor for postpartum hemorrhage? A previous history of postpartum hemorrhage, okay? If it happened last time, it's going to happen this time, and we should know about it and be prepared for it, okay? So think about it in those categories. Broad chronic risks during pregnancy, acute symptoms that suggest there's something going on right now, and then the past history. So here's the role of we did a study. I've presented this to you before. It's actually a super cool study. We took 50,000 women who were monitored in the Intermountain system, 52,584. We took 31,550 of them, and we said, okay, in that first hour of you being on labor and delivery, can we identify the factors that will predict that you're going to have a problem? Okay? So we trained on 31,000. We came up with an algorithm that had 10 key factors. And this was meant to say within the first hour, and then we tested it on 21,000 additional patients, and it worked wonderfully. Okay? What we found was there were 243 cases of people who had a pH less than 7.1 and 31,000 controls, and we had 162 cases and 20,000 controls in the validation population. Okay? We looked at adverse neonatal outcomes, and then we created a risk model, and then we tested our risk model in this situation. There were 31 variables that we looked at. These are the 10 that were most important. Maternal age. If a woman has advanced maternal age, she's at higher risk of having a problem. Okay? Now, there's actually a risk scoring system. You get 1 or 2 points for each one of these things, and when you add them up, if your total score is above a certain cutoff, you're at high risk. So maternal age, extremes of maternal age, current BMI. The higher your BMI, the more likely you were to have a complication. Okay? Gestational age. These were limited to 36 weeks and greater. So 40, 41, 42-week babies have more problems. The older the baby, the more problems you have. Okay? Parity. If you're nulliparous, higher chance. You get points for being nulliparous. If you're multip, you're going to probably be okay. Okay? That's why I do multips only at my practice, right? You've seen those wisdom teeth only dentists. I'm the multips only obstetrician. Pay your price, and then you can come see me, right? Okay. So induction. If you're being induced, that was on the list. Diabetes, hypertension, preeclampsia, abruption, and a Category 2 fetal heart rate tracing in the first hour of labor. Yes?
On induction, did it matter if it was just elective or if it was indicated?
We didn't break it down like that, so I'm just going to say any kind of induction, but I think you're right. It's mostly people who were induced for an indicated reason, right? And there's going to be some overlap with the diabetes, hypertension, because a lot of those people are being induced, and post-dates, okay? These are the 10 things, okay? And if you use them, you can break them up into different scores. And if you look at the high-risk group, the highest risk group, and you come down, there's also an intrapartum score that you apply. You can get a group of people whose risk of having a cesarean section is 50% and whose incidence of a pH less than 7.1 is 11%. Okay? This is huge. Okay? Those 10 things are the things you should be thinking about. Now, I'm beside myself because I keep thinking we should be using this, but I haven't found a way to use it on labor and delivery. But someday, when I have time, when I don't have to make these lectures and I can actually do something else, then we can do this. So, once you know that your tracing is adequate and you're monitoring the baby and you can actually interpret it, and you've identified the risk factors, pregnancy factors, the current acute factors, and the previous history, then you need to say, what is my current status? Where am I starting from? Now, I don't know, this is an older version of my talk, sorry, I had it all in different order, so I'm bummed that I put the wrong one on here. But anyway, you guys know already that if you have moderate variability, this predicts a pH that's greater than 7.15. And you can be 98% sure that the pH is greater than 7.15. Okay? That is the number one thing. But it's got to be true moderate variability. It can't be close, almost minimal. Okay? Accelerations. Now, I went through and tried to find the same thing. What's the predictive value of accelerations? And I couldn't find a number to put on accelerations.
In the A1 it says 7.19.
7.19, the pH. But what percent? What's the negative predictive value? So the negative predictive value says if I have 100 babies that have moderate variability, 98 or more of them will have a pH greater than 7.15 or 7.2. Okay. With accelerations, I can't give you that number, but it is if they're present, it's about the same. Okay. You should never try to do scalp stim during a deceleration because that doesn't count. Now, the other thing you should be looking for is the absence of tachycardia. So if in the first hour there's normal baseline, moderate variability, and accelerations present, you know that your pH is normal, right? And I've showed this graph. Have I showed you this graph before? Oh, we need to have this talk, okay? Because this is actually a really cool graph. And let me explain what it is. They have done studies where and this is using base deficit instead of pH. But you know that base deficit and pH are both markers of whether the baby has had hypoxemia for a prolonged period of time. And you think of base deficit of -12 the same as a pH less than 7.0. Okay? So in this case, I'm using base deficit. And what I'm saying is, most pregnancies that have not had any problem with their pregnancy will come in, when they walk through the door, their base deficit is -1 or -2. That's where people start from, okay? During the course of the labor, just regular labor, your base deficit will drop because the baby is working. It's being intermittently holding its breath with those contractions. The base deficit will drop 1 point for every 3 to 6 hours during labor. Okay? So if you start at -2 and you have, let's say, a 12-hour labor, you're going to be right around -4 at the time that you're complete. Okay? Now, when you start pushing, it's harder on the baby, and the base deficit drops 1 point for every hour. So if someone walks in with a normal baby, no problems, no pre-existing problems, they'll be -1 or -2. They'll drop 1 point every 3 to 6 hours and be around -4 at the time they start pushing. And if they push for 2 hours, their base deficit will be -6, well above where you would expect. But there is documentation that these conditions, IUGR, oligohydramnios, preeclampsia, maternal diabetes, long labor, abruption, and post-term, when those people walk on, their base deficit is actually lower. If you're post-dates, you're actually starting at not here, you're starting down here. And when you're starting here over the course of the labor, even if you tolerate labor the same, there's no margin for error. So where you're starting right here, the factors that determine whether or not this baby is going to have a hypoxic ischemic injury depends on a couple of key factors. 1, where did we start from? Okay. 2, how fast is this dropping? And the rate drops faster the more decelerations, the longer you have them. In fact, you can actually go through and say for every minute of deceleration that you see, the base deficit drops 0.5. If you have one prolonged variable deceleration of 1 minute, your base deficit has dropped 0.5. You went from -4 to -4.5. Okay? Now, when that comes back up, every minute that it's back up, you can restore the system. But it takes 5 minutes to go back to -4. You need 5 minutes for every 1 minute of deceleration. 5 minutes of normal baseline to recover, to get rid of the CO2, to get the oxygen back in the system, and to recover your base deficit. Okay? So you can actually look and say, I'm having decels every minute, and they're coming every 5 minutes. I can tolerate this for several hours. But if it's coming every 4 minutes or every 3 minutes, every time you have a deceleration, you're dropping 0.2, 0.2, 0.2, and you can actually calculate how quickly your base deficit is dropping. Question?
Okay, so on post-date,
Yes. Yeah.
Come in and they're already lower. And then oftentimes their inductions are cervical ripening for
Right.
hours and hours and
Right.
hours, and then
So for those online, for a post-8 who comes in and has a base deficit that's not -2, it's -4, -5, then they have an induction that goes on for hours.
do you count the cervical ripening hours?
Do you count the cervical ripening hours? The answer is I start to count when they're having regular contractions that I can monitor that are strong enough that I think that their the intrauterine pressure is greater than 30 millimeters of mercury. The intrauterine pressure is greater than that, okay? So, if they're contracting irregularly and mildly, they're not perceiving them, I don't count that. But if they're uncomfortable, if they're palpating firm, that's when I would say, okay, this is when a baby's holding its breath, okay? Now, I promise you at our next lecture, I will talk more about this because this is something that I just found recently, and as I was thinking about that, this really makes a lot of sense. And I thought I had told you guys this before, so I wasn't going to do it, but I'll do it next time. So, but what I'm teaching you here is that where you start on this admission point makes a huge difference about whether your baby's at risk or not, okay? So once you determine the current pH, then the next thing is find the presence of are there recurrent decelerations? Remember, minimal or absent variability and decels is associated with a pH less than 7.15. But the positive predictive value is only, out of 100 women who have minimal or absent variability and recurrent decelerations, only 25 of them will have a pH that's less than 7.15. Okay? But that's a significant number. So your likelihood of acidemia increases with the depth of and the recurrent nature of the decelerations, how often they're happening, especially with late decels and minimal or absent variability. Okay? So far, I've given you a checklist that says, make sure you have adequate tracing, that you can interpret, identify the risks so you know where you're starting from, and whether there's an acute process going on. Figure out what your pH is right now, and figure out whether there's a risk that it's going to drop quickly, okay? The last thing I would put is create a plan for care with the whole team. By the end of 1 hour, everyone on the care team should understand this is our plan. This is what's going to happen, okay? Now, name some things that you think would have to be in that plan.
Well, if none of those are at where you want them to be, then I think you make a plan to say how long, at what point will we stop tolerating that?
Right. So it depends. It depends on the situation. But let me show you what I thought. Okay. Here's my checklist. 1, you need to complete the evaluation and treatment of pre-existing risk factors. Okay. So if she comes in and she's here for preeclampsia, one of our plan, okay, with the doc or the midwife is, we're going to finalize the diagnosis. Does she have preeclampsia? Is it with severe features? Do we need to treat with MAG? Okay. Does she have diabetes? Okay. How are we going to manage that during this pregnancy, during the labor? Does she need to be on an insulin drip? How often are we checking her blood sugars? She has a history of postpartum hemorrhage. How are we going to prevent that? What's the plan for that? Are we going to have extra meds available? Do we need to have a balloon in the room? What are we going to do? Is she at risk for shoulder dystocia? Okay, we're going to do dystocia precautions. Everyone on the team needs to understand. What does that mean? That means we're going to break the bed down. We're going to have a stool in the room. We're going to have extra people available. We're going to have extra people come. That we're prepared for that. And if she's a TOLAC, we're going to say, okay, we're going to watch for signs and symptoms of a ruptured uterus. Okay? So the first thing is to make a plan that everyone understands how we're managing the chronic problems that have been going on. Is that okay? Then the second thing is, how are we going to manage this labor? In my mind, that means, are we going to augment? How often are we going to check her? How are we going to do low dose or high dose PIT? If it's an induction, how are we going to do that? How long are we going to do that? And do we need internal monitoring? Is our monitoring adequate? Okay? Then, we need to identify and treat pre-existing fetal risks, okay? There are some babies who are going to need special resuscitation. Those who have been exposed to certain medications, right? those who have meconium present, right? Those who have fetal anomalies. A big one is Rh isoimmunization, right? We need to notify the NICU that that's the case. Or they have GBS. Is there a fetal thing, a special fetal risk that we need to be accounting for? Okay. Next, what's our plan for ongoing monitoring? Are we going to do standard intervals or more frequent? Okay, now someone raised their question. I was talking with a group earlier, and we were saying, okay, what does that mean? What is it? What's the standard interval for monitoring on labor delivery, a low-risk patient? Every 30 minutes during the first stage of labor, and every 15 minutes. So if you have someone who's completely normal, no risk factors, nothing, and the tracing's fine, it's every 30 minutes, right? That means you're going to evaluate the tracing every 30 minutes. Does that mean you put a note in the chart every 30 minutes? For IHC, if it's low risk, you're assessing the fetal heart rate every 30 minutes and putting a note in there, right? If it's high risk or there's a problem, it's every 15 minutes, okay? Or it may be continuous. Again, do I need internal monitors? This is a great time to ask the provider, when do you want me to call you? Okay? Some people will say, I don't. Just call me when they're crowding, right? Others will say, I want to know about every little thing. Okay? What's the plan? Let's get on the same page here. And then identification of the primary caregiver that will be responsible for the care. By the end of that first hour, who's responsible? How do I contact them? Are there special issues about their availability? For example, when it's me, if I'm not in the hospital, I will say, I'm going to be 15 minutes away. Okay? And I know that you know that means I'll be here in 30 minutes. Right? Because you're like my family, and you automatically double anything that I say. Right? But I'm trying to tell you, what I'm trying to do is set an expectation for you. If you call me and need me, the fastest I can be here is 15 minutes. So be thinking ahead about that, right? And I'll often say, I'm on my cell phone, call me. Okay? But if you can't get me, this is who the backup is. That way it's clear who's on the team. So I guess maybe what we should put here is identification of the team. Does that make sense? Would you add anything to this list? Yes.
Did we have the first OB call or whatever that person? Would you include them right in the first hour to let them know?
The question is, since we have a first OB call or a laborist in-house here, would you include them in the first hour? My answer is, only if the physician or the midwife that's on feels like they should be notified. Okay? And I told the people at the small group this morning that your communication and your plan should be with the primary care doctor. That other person, the first OB call, gets included when there's a difference of opinion or when you want additional information. But if I would say, I will tell you, if it's my patient, and I'm not planning on being here in-house, and there's a risk for shoulder dystocia, then yes. Then part of my plan is to tell them the first OB call. I'm 15 minutes away. I don't know how quickly this is going to go. If you get called in there, we're doing shoulder precautions. This is what, she has diabetes. Her last estimated fetal weight was this. She's had a baby that was this big before. I think it's just good to have them in. The more we include them, the better. Okay, so let's do a case. This is a quick case, but this is a case to illustrate the first hour, okay? It's a 24-year-old gravid 1 pair 0 at 37 weeks and 4 days, comes in complaining of vaginal bleeding, right? Presents at 03:50, dark 50 in the morning, right? Worst time ever. This actually should be the hardest time for us to mobilize a team, don't you think? 3 o'clock, possibly? The vitals were 37.0, temperature, pulse was 86, blood pressure is 118 over 79, and she weighs 182 pounds. I don't know how tall she was, okay? So, any concerns here? The vaginal bleeding, right? But she's not tachycardic, she's not hypotensive, things look good. I don't have any other information about her, okay? This is what happened. You put her on the monitor at 3:47, okay? Okay, that is the first 2 minutes. Who wants to take this one? wants to take this patient? Come on, raise your hand. Somebody. Okay, tell me about it. What do you think? Great. So that looks sinusoidal, right? Well, a sinusoidal pattern. Okay, it's not a sinusoidal pattern. It looks like a sinusoidal pattern, right? A sinusoidal pattern looks like a sine wave. It's smooth. It's about the same amount above and below the baseline, right? That looks like a sinusoidal pattern, and if it continues for 30 minutes, or 20 minutes, if it continues for 20 minutes, it's a sinusoidal pattern, okay? But in someone who comes in and says, I'm bleeding, and you see this first, you should be thinking, I'm not waiting 20 minutes to prove that this is a sinusoidal pattern, right? Okay, so what would you do right here? What would start an IV, put her on O2, give her fluids, call the doctor, turn her on her side. Okay, and assess the bleeding. Right. Now, would you check her cervix? I think the way you would do is say, do you have a placenta previa? Is there a concern for that, right? If I probably wouldn't check her unless she said, I feel like I need to push or something like that. I'd be really careful and get my team with me as quickly as we can. Okay? All right. So you're in. How long does it take you to start an IV? Okay, 30 minutes later. Right. So you're putting in an IV right now. You're putting in an IV, right? Here's the next two minutes of the tracing. Okay, are you feeling any better? Okay, what can you do to reassure yourself here? Is there a baseline? Maybe. I don't know that we have 2 minutes of tracing to actually get a baseline yet, right? You can't tell the baseline in the beginning where this is going up and down, up and down, up and down like that. So I don't know that we really know what's going on yet. We just see that it's flat. We see that there's no really short-term variability, and there's regular oscillations around instead of irregular and varying oscillations. So this may be a sinusoidal tracing in some fashion in a woman who's bleeding, okay? So then we do this in the next 2 minutes, and we do this, and we do this. There's a contraction. Would scalp stim help here? Maybe, but probably not, okay? Would acoustic stim help here? You can try it, but it's hard. At this point, I'm not even sure that we can adequately establish the baseline. The variability is so concerning, I think we need to be mobilizing things. What about a biophysical profile? Okay, so this is a hard thing because a lot of people will say, oh, let's get a biophysical to reassure ourselves, okay? In this setting, that would take 20 to 30 minutes or more. And it's going to take you down a pathway where you're just trying to reassure yourself and not really seeing what's happening, okay? This tracing is so concerning that we need to be delivered in 20 or 30 minutes if it doesn't get better fast, okay? So I would not do a biophysical profile. In fact, it's rare to do a biophysical profile on someone on labor and delivery that you're monitoring, okay? There are places for it, but it's rare. If I told you that she came with vaginal bleeding and decreased fetal movement, then you should be double timed. It should be twice as fast. Okay? Now you're already going as fast as you possibly can. Excellent question. Is this baby or mom? So here, by this time, I hope that the doctor's in the room and can help you say, does she have a previa, yes or no? Let's check her and see how far dilated she is. You could put internals in. Maybe she's almost ready to deliver and we just don't know yet. Doing a bedside ultrasound here to confirm that this is the fetal heart rate, putting on a pulse ox, perfect. That's our checklist, right? Number one thing on the checklist is, do we have adequate tracing for interpretation? And right now, there's no missing data, right? And there's enough data now that we can get a baseline, we can talk about variability, we can talk about those D cells, we can't really tell the contractions, we're starting to see that, right? One thing we haven't done yet is confirm for sure that this is the baby and not the mom, right? Okay. Then, here's the next minutes. Okay, at 04:30, it looks like that. It looks like this. and then we go to the OR. Okay? I'm going to tell you, I reviewed this tracing, and I thought, I was so proud. This happened here, right? I was so proud of how quickly this happened at 3:50 in the morning that I went back through and put on at what happened at each moment. Here's what you guys did. Check it out. Whoops. So here, at 3:51, 3:47, she gets on the monitor. 3:51, someone recorded vitals. At 3:52, there was acoustic stim tried right here. At 3:54, contacted the MD, will come to evaluate. 3:55, this is less than 10 minutes. Initiated 2 to 1. Someone recognized, I need more help. We need more nurses in here. We're prepping for C-section. 6 minutes after she was called, the doc's in the room and is performing an ultrasound to confirm that we have the baby and not the mom, right? Now, I'm not sure if this came through here. It didn't. But what happens here is we start oxygen, we give a fluid bolus, and I can't remember what happens right here, but we then take her to the operating room. She delivers over here at 4:17. We're in the operating room at 4:13. She's got under general, we called anesthesia. So at 4:05, at 4:03 we put on oxygen. At 4:04 we gave her a fluid bolus. At 4:05 we're talking to anesthesia. At 4:06 you're turning off the monitors and rolling to the operating room. At 4:13 you're in the OR. At 4:14 she's undergoing general anesthesia. At 4:16 we're making our incision. And 4:17 the baby was delivered. Yeah, that is awesome, right? So this is a great example of how the first hour also can be the last hour sometimes, right? Okay. Oh, look at that. Here they go. Or, let's see if I got them right. 4:03, oxygen. 4:04, bolus. 4:05, NICU. Oh, NICU. 4:13 in the OR. 4:15, general anesthesia. 4:16, incision. And 4:17, delivery. Fantastic. 30 minutes from door to delivery. It couldn't be done faster than that. Here's the outcome. Oh, I don't have the outcome. Shauna, what was the outcome? She'll tell us the outcome. So, let's think about our checklist then. Number 1, did we have adequate tracing? Did we evaluate the tracing appropriately? Yes. We had tracing that we could see, we confirmed it was the baby's, and we interpreted it appropriately. 2, did we identify the risk factors? Yes. She came in with vaginal bleeding, and we recognized that and went quickly, right? Number 3, what was the pH at the beginning? Did we recognize that the pH was not 7.2? Yes, we did. We saw the minimal variability. We didn't see any accelerations. We tried acoustic stim. It didn't work. We recognized that this pH was less than 7.2. There aren't any really big decels here, but this was bad, and so I think our idea is it doesn't matter whether this is progressing, how quickly this is progressing. We decided it was so bad we were going right then and not going to give it any more time, right? And we intervened in an appropriate fashion, and we made a plan that involved the whole team, where our plan of care had the doctor there at an appropriate time, notified NICU, and did an appropriate intervention, which is cesarean section, as quickly as possible. That's the checklist. Great job. Okay, what was the outcome?
APGAR 014.
APGARs were 014?
pH, the Venus was 6.82.
The Venus pH was 6.82.
Base excess of 20.1.
Base excess of 20.1. Okay, so here's the baby who walked in. Here's the mother who walked on to labor and delivery, whose baby's pH or base deficit was already 20. And did we figure that out? Yeah, we did, right? That's great. Now, was this a success?
It's a baby.
Maybe. From a baby perspective, I don't know whether you can call it successful or not. But what I can tell you is we provided optimal care. That's a success. That's the only thing that we could change, was whether or not we provided optimal care here. Right? So good job. Now let's talk about the last hour. I've been talking to all my partners as I go around saying, hey, I'm going to give this talk, and asking them what they think about the first hour and the last hour. And I asked where, and he said this. And so I thought, that's a good quote. I'm going to put it on here. He said, you know, it's kind of like if you're climbing the mountain, and you're climbing Mount Everest, you shouldn't be saying, oh, I'm almost at the summit, and looking at the top and thinking I'm going to get there. You should be thinking, how am I going to navigate this last 1,000 feet safely? Okay? Yes?
It does say velamentous cord insertion, though.
Velamentous cord insertion. Okay. So, if it's a velamentous cord insertion, it may be that the blood was baby's, not mother's, right?
And it says bleeding from the cord.
Bleeding from the cord. Okay. So this baby was anemic, probably. Okay. So anyway, I want you to think about that. The last hour, instead of saying, oh, we're going to deliver in just a minute, it's, okay, how are we going to get safely from here to the delivery? Okay. So here's my last hour checklist. Okay. It's kind of similar. 1, make sure you have adequate tracing, but this time make sure there's no missing data or artifacts. And make sure you're tracing the fetus, not the mother. Is she having accelerations with pushing? Here's an example of a tracing that you can't tell what's going on, because the key parts of this are missing. If this is when you're complete and you're about to start pushing, if this is what the tracing looks like, you need to fix that before you push. Right? So you need to put a scalp electrode on, right? Now here's the same baby a little bit later with the maternal pulse ox on. We were monitoring the mother. So they separated out. Okay, let's keep the pulse ox on and the fetal heart. Okay, now we've got the baby and the mother. And then they took the mother's pulse ox off, and later they monitored this, which turned out to be the mother again. Okay? And you can tell because every time she's having a contraction, she's having an acceleration. Okay? So, again, the last hour checklist starts when you're in a transition phase. So, if the person is having decelerations that make you think we might have to deliver soon, you should start going through your checklist. Is my tracing adequate? Okay? When you get to complete, you should go through your checklist. Is my tracing adequate for me to start pushing? Or can I make it better? Now, sometimes you can't make it better, right? But you need to try. After you've checked the adequacy of the tracing, then you need to establish situational awareness. And this is kind of interesting because we talk about the loss of situational awareness, but in order to lose it, you have to create it, okay? And this is a different idea that I've been thinking about. I'm thinking, okay, well, how do I create an awareness of what I should expect, okay? When I get to complete, I'm going to say, okay, this is a multip. We should push this baby out in 30 minutes. The tracing looks okay now. So I expect no decelerations. I expect that we're going to deliver in 30 minutes, okay? Now I'm aware. In 30 minutes, if we haven't delivered, I need to look at it again. Okay, well, what's going on? How much longer do I have? Okay? So I'm setting times for reevaluation in my mind. Let me tell you about an experience I had. One time I got called into a decel. It was a prolonged deceleration. And I came running in like a Keystone cop. Whoa, what's going on? And there's the mom, and the midwife was pushing with the mom, and they said, we've been down for, 10 minutes. And I said, well, what's going on? Well, she's a multip. And I'm thinking, she should just push this out. Just push it out. And, well, we've been pushing for an hour. Okay, wait a minute. This is G5, and it's an hour? There's something wrong, right? And that's because we didn't set the situational awareness at the beginning to say, wait a minute, and it's important for me to know because I walk in, she's a multip, okay, I'm just going to pull this out, right? But if she's been pushing for an hour, I'm going to say, we need to move to the back and be ready to maybe do a C-section because I'm not sure I can pull it out. This baby's in a malposition, or it's too big, or there's something. Does that make sense to everybody? So just kind of in your mind say, this is what I expect to happen. And give yourself a time frame, and that is when you're setting your situational awareness. And that way you give yourself a time when I'm going to reevaluate. Okay? Now, confirm the pH again. Am I worried about where we are? No, we've had great tracing. We're fine. We can push for 2 hours. But, okay, what's the pH here? Okay. This is what the tracing looks like when you start pushing, right? You can't tell what the pH is. So again, you don't have adequate tracing here. And you've got to figure out what the baseline is and whether that's moderate or marked variability and whether you can trust that, right? So make sure that you can say whether your pH is normal or not, and then is there an ongoing disruption of the oxygen flow to the fetus? If so, how often is it happening? How many minutes in between? Are we letting the baby breathe for 5 minutes? Great. Then we can tolerate a 1 minute decel. Okay? If we're letting the baby breathe only 3 minutes, we got less than an hour, and we got to go. Okay? How deep are they and how long are they? The other thing I'm going to add right here is this. You should say, is there something happening right now that is telling me there's an acute change? Is there bleeding that just happened, or pain that's new, or is there a sudden prolonged deceleration? Okay, these things tell you you've got to go quicker. Okay, and then if they're pushing this much, if you're pushing this frequently, you don't have time. You've got to let them breathe through one and see if you maintain the heart rate, and then push every other. Okay, now. The last hour checklist should be initiated when you think delivery is going to occur within the next hour. This might be at complete dilation. It might be when there's a serious change in the heart rate. Start having big decels, okay? Or there's prolonged deceleration, and you go through your checklist, okay? Here's case number 2, the last case. It's kind of long. I'm not going to have anybody read it. We're going to look at it together and kind of just go through it and talk. Yes?
So on that last one, you talked about looking at the heart rate and deceleration, but her contractions were so close. Would you have gone through? Can I turn this open on?
Yes. I would go through in that last one. I would go through the whole exercise of trying to space those contractions out. Turn the pit off. Give her a fluid bolus. Reposition her. Okay. I can say fluid bolus so much they're probably full of fluid and rolling out the door, right? But that's the only thing I have to give you. It's my hammer to give you for every nail. This might be where TURB might be indicated, okay? Or if I always look and say, okay, if I don't push, does the baseline stay normal? If it does, there's no deceleration when you don't push, then it's worth waiting and pushing every time. But if you stop pushing and you get the big decel anyway, then it's a race. It's a race to see how quickly you can push it out. And that's when you need to start thinking, I'm just going to pull it out, or we need to do a section. Okay? So, case 2, a G2P1001 at 41.3 weeks presented with a history of a prior cesarean section, 39 weeks, 2 years ago. She had SROM at home 10 hours earlier. Temperature was 36.8, pulse was 76, blood pressure was 101 over 63. She was admitted again at 2 o'clock in the morning. Okay, cervix was 2+, 90 and -2, clear fluid, estimated fetal weight 7 pounds, BMI 24. What questions do you want to ask me? Baby's moving normally when she comes in. Okay, she's had normal movement. She's been in labor for a long time, and she ruptured her membranes. She didn't come in because she wants to have a vaginal delivery. The question that should be going through your mind right now is, why did she have a C-section last time? Okay? And the answer is that she had a C-section at 3 centimeters after being in labor for a long time. Okay? So she never really got into active labor last time, and she presents now late because she thinks that if she comes in, we're going to do a section on her immediately. Yes? Right. So what's her GBS status? Her GBS status is negative. Okay? And if there's no evidence of infection, that's a good thing. She's never had a vaginal delivery. She's post-dates. This baby may not tolerate that, right? And we're early in labor, and she's already been, we're early in dilation, but she's been in labor for 10 hours already. This baby may already have problems. So let's look at the first tracing. Oh, it looks good, right? Here we are. Okay, so this is right around 1 a.m., okay? There's a baseline of 125. I would call this either moderate I would call it moderate or mild or minimal variability, but probably moderate. There's a deceleration there at the end. I'm not sure if that's an early. It looks like it's probably an early. We're right with the contraction. I don't see any accelerations here, and the contractions are hard to monitor. They're coming frequently. Okay. Here's the next 8 minutes. Here's the next 8 minutes. Here's the next 8 minutes. No, this is not a fetal scalp electrode. Okay. Here's the next 8 minutes. Here's the next 8 minutes, and here's the next 8 minutes. And the question then is, okay, that's their first hour. Okay. So go back and look at that. Let's go through our checklist. 1, do we have adequate tracing? No. Yes and no. We have periods where it's good. We can tell a baseline. We know that the pH is okay. We see occasional accelerations and we see decelerations, right? And there's nothing recurrent. But it's not continuous. We can do it better. Okay? So we want to try and adjust to see if we can get more continuous. Are we adequately monitoring those contractions? I don't know. But I would say at checklist number 1, I want to avoid 8-minute or more segments where we're missing the tracing, okay? Unless she's going to the bathroom or something, okay? She might be. I can't remember if it was. Yeah. Oh, yeah, she got fentanyl, so she's getting her epidural. There you go. Okay. Now, was the tracing adequate? Did we identify the potential risks? Yes. We're watching for infection. We're watching for rupture of the uterus. We're watching for arrest of dilation. Those are the things that we think that are going to happen, right? Okay. Can we determine her pH? Yes. It's 7.2 or higher right now. We're okay. Is there a process going on that's going to drop her pH? Probably not. It seems like she doesn't have recurrent decelerations, so she's probably going to be okay for us to continue to watch. Let's create a plan. Okay. Should we augment her? Maybe or maybe not. It would be reasonable to say, let's check her in an hour and see. And if she's making progress, let her go. It's okay to start some PIT. Would we do low dose or high dose? Low dose PIT on this one, probably, right? She's got a previous cesarean section. How often are we going to check her? Does she have a pre-existing condition that we need to be treating? No. I think we're okay, right? Call the doctor. This patient's here. Want you to know that her tracing has looked good. She's had one kind of early, but otherwise okay. I think the normal baseline moderate variability. Otherwise, it's category 1 tracing. I'm having a little bit of difficulty getting it continuous, but we're working on that. And she's contracting. She was 2+. Would you like me to check her again in an hour and give you a call, or if she's not changed, start some PIT? How often do you want me to call you? What's the number? How long will it take you to get here? Okay. Here's the next. This is now 6 o'clock in the morning. Looks fantastic, doesn't it? Baseline of 130, moderate variability, accelerations, maybe one variable deceleration right there. There are contractions coming frequently. It's hard to interpret those contractions, right? This may be tachysystole. I don't know whether she's getting. We're just starting oxytocin on her down there at the bottom, right? So this is a progress note. This is written by the nurse. She's comfortable with her epidural at 6:30. Her vitals are fine. There's been no cervical change now in 5 hours. She's still 2+. We're going to put an IUPC in. Okay? And it sounds like we're starting PIT. This is the tracing now at 9 o'clock, 3 hours later. And I took out big segments where there wasn't anything worrisome. Okay? So now we're at 9. Baseline, 125, moderate variability. I don't think that's an acceleration there, but there's one variable here. Now there are accelerations here, right? And we're seeing contractions much better every 3 to 4 minutes, okay? With variables that are lasting less than a minute or just about a minute, but not recurrent at this time, okay? That might be a little bit of a variable with a late return, okay? And another variable. Now we're skipping from 9:50 to 11. And this is an hour's worth of tracing from 11 to our next note at 11:56, 58. So, are we worried? No. This baseline is essentially the same. It's in the I would say it's in the 120 to 130 range with moderate variability accelerations. There are decels, they're not quite recurrent, but they're happening frequently, and we're going to watch those, right? And the SOAP note says she's comfortable, her vitals are stable, she's now 4. We recognize this is a category 2 tracing. She's still in latent labor. Let's keep going with the Pitocin, okay? So here's now at 12 o'clock. This is right after this note, 11:58. Wrote the note, walked away, and this is what it looks like right after. Boom, boom, boom. Okay. What's happening? So, her contractions may be stronger, okay? We went from a normal baseline with moderate variability and occasional variables to more frequent variables that are lasting longer and are deeper, right? And our baseline is kind of, our variability is kind of settling down, okay? What could be causing this? A cord. Okay, so we just barely checked her. We didn't feel a cord there, right? So, but it might be cord occlusion somewhere. What else could be causing this? A uterine rupture. Okay, so maybe she has a rupture. How would you tell if she had a rupture? Loss of station, bloody discharge, blood in her Foley. The contraction pattern changes. She has pain, okay? She doesn't have any of those, okay? But I think it's wise to think about that in this case. I think we should think this is probably cord occlusion, and we're going to try and fix it. So what we're going to do is we're going to reposition her, and voila, it gets better, okay? But we thought about ruptured uterus, and we looked for other things for that, and it got better, okay? So now this is 12:38, 12:46. Now I'm jumping to 5 o'clock. It was pristine, perfect until 5 o'clock, okay? Here we are at 5, and we're now at 5:15, and we're now at 5:23, and we're now at 5:31, and 5:39, and 5:47. Okay, are we worried about this? Baseline's 120 or 125, moderate variability. There are, I don't see any obvious accelerations. I don't count that one right there, but I would say that's probably an acceleration. I think the pH is greater than 7.2. She is having some subtle decels, but I think we're okay, right? So at 17:56, I wrote this because I thought it was cool. She's resting in the throne position, no pain or pressure. Her blood pressure is stable. Her pulse is the same. Her temperature is fine. She's still 4 centimeters. We called the doctor, okay? So this is a midwife patient. We called the doctor and said, will you come and check this out? Because we're having an arrest of dilation, right? We're still not in the active phase. And they said, well, just keep going up on your pit and titrate to the MBUs, and let's recheck her in 2 hours. Anyone have a problem with that? Yes? What's your problem? I think what they're... She was a C-section for... Right, she was a C-section for arrest of dilation already. Have we waited too long? She's been 4 centimeters now for probably 5 or 6 hours, okay? So the definition of arrest of dilation depends on when it happens. If it happens in the active phase, you need to have adequate contractions after 6 centimeters, 6 centimeters more. Active contractions with no change in your, adequate contractions with frequency, intensity, and duration, and MBUs that mean that it's adequate, with no change for at least 4 hours. Okay? In the latent phase, before you get to active, you can wait longer. You can wait 12 or up. I mean, for an induction, you can wait a long time. But I think you're right. In this case, with a previous cesarean section, and she had an arrest very early, we're headed down that path. I think it's reasonable to wait for 1 or 2 more hours. If this doctor was me, I would be saying to the patient, you know, I'm worried that we're headed there because you've been for a long time. The baby is still okay, and it will probably tolerate another hour or 2. Why don't we slowly go up on the Pitocin? When it says titrate to MBUs, what they're trying to say is get her adequate, but you don't have to go past that. I'm not telling you to go all the way up to 30. I'm telling you to get to the point where the contractions are adequate, and let's just let them be adequate, okay? I think it's reasonable. You could say, well, let's look again in 1 hour, but I think 2 hours is fine, and we're watching it close, okay? So here's the next 2 hours. Looks fantastic, doesn't it?
So is she 24 hours?
I'd like to be in the baby.
Probably. No, because she came, well, she might be. She made 24 hours rupture. Yeah. She was 10 hours when she came in, so we're just kind of hitting that time now. So at 2:18, they don't, or 2018, they don't say anything about her symptoms. Her pressures are fine. She's not tachycardic. Her temp is fine. They call the baseline 140 with moderate variability. Excel is present. They say that MBUs are adequate. Her cervix is now 6. 2 centimeters progress, and she's dropped 1 station. So we're going to keep going with our PIT at 10 milliunits per minute, million international units per minute. Here's where we are at 2018. So here's the next thing that happens. So here's 2028 to 35. Then here's 2035 to 2043. And then she's 6 centimeters dilated right here at 2049. And at 55, she says, ooh, I have really bad pain in my shoulder and my right lower quadrant.
No.
Okay, now I'm presenting her at a stripper view, so everybody's saying, oh, I know what this is, right? But if you were there, what would you do?
Try to alleviate the pain.
Try to alleviate the pain, right? So what would you do to do that? Reposition her, have her give herself a little dose, okay? Now, if you think it's a rupture, what else should you see? Blood. Lost the station. We haven't lost the station. How about her pulse or her blood pressure? Okay, I would go through the whole list and say I don't see any evidence of rupture here. The tracing, I see mild variables. I think I'm concerned about it, but I'm not going to rush back and do something at this minute. So I'm going to say the things I would do to resolve her pain. This is the next 8 minutes. Okay? And her blood pressure is 112/55. Her heart rate's now 93. It's gone from 70s to the 90s. It's going up. Okay? And then here's the next 8 minutes.
So, Sean, it says there was a pitocin age there. Was it up or down?
I don't know whether they turned it off or not. It also says that they dosed her epidural. They had anesthesia come and dose her epidural. Okay? So now, here we are. 10 minutes, 12 minutes after she said, I'm having this really bad pain in my shoulder. Now what do you think? Her pressure is 111/57. Her pulse is 86. We just dosed her.
I was here one time. Seems like.
Yes. Yeah, it was 120 and now it's 150. Okay. I don't know what her temperature is right now. But now I should be getting worried that we might be seeing a problem, okay? Because she's got this incredible pain, and now she has changes in her fetal heart rate tracing, and I know I've been watching for this, right? Because I expect that every time someone's having a VBAC, right? And now it's here. Okay, so now what am I going to do?
22 or 23.
Section her. So we're going to turn off the PIT. We're going to call the doc. We're going to have him come in. We're going to say, I'm calling because I'm afraid she has a uterine rupture. This is a patient with a previous history of a cesarean section who's been in labor now for 20 hours. She was 6 centimeters dilated, making a little bit of progress, and suddenly had shoulder pain. And we've dosed her, we've repositioned her. It's not better. Her vitals are stable, but now I'm having repetitive, severe variables. I need you to come in, and we're going to move to the operating room. Okay? And if you're at home, I'm going to call the doctor that's in the hospital. Okay, that's the communication doc. Yes.
Can you explain how shoulder pain and rupture together?
So a couple things. If you have an epidural, you really can't feel anything in the lower part. So having pain in the right lower quadrant with an epidural means it's bad. Okay. Shoulder pain means you have diaphragmatic irritation. She's probably got blood in her peritoneal cavity that's irritating her diaphragm, or air, right? Amniotic fluid. So here's the last part of the tracing. We've just started the last hour of the tracing, right? A dramatic thing has happened. We know she's going to deliver in the next hour. First, is our tracing adequate? It is. Is it the mom or baby?
I'm like, I called it.
It's probably baby, but it may be worth putting an FSC on or just having somebody look to make sure that it's baby, okay? All right. So we've got an adequate tracing probably, but we might consider putting an FSC on here, okay? Second,
And I think it's mad at me, but
what's the second thing in our...
oh, well, I guess you said it's fine.
Okay. We know what our risk factors were. There's something that's happened that's changing, okay, and we suspect that there's a problem. We're communicating with the physician and the doctors and the care team, and we're looking at our pH. Our pH to this point has been fine, 7.2. How long do we have?
Okay, but
Depends on what happens next, okay? If she has a prolonged deceleration, then we've got to run, right? Because we got 15 minutes, okay? She keeps having these significant variables. We might have a little bit more, but you don't have an hour here. Because if this is really a uterine rupture, this is going to go much faster.
out of there.
So our pH was 7.2, but a dramatic thing has happened, and I think that we're going to drop in the next 15 to 20 minutes. Mostly because this part of the tracing is covered. So when I show you the next bit of the tracing, you're going to say, oh, and 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 oh. Is that mom or baby? It's hard to tell. That's a scalp electrode now, I think. And then we're giving terbutaline. And this is in the operating room. Yeah, and then we deliver. Okay? So, now, do you see how when that dramatic thing changed, we went through a checklist to say what's going to happen, and we actually set our situational awareness there. We said, okay, I think if it could go into a prolonged decel. If it does, we have to really go. If it's just repetitive decels, we need to go quickly. If it calms down, the pain gets better, then the doc's going to come and we're going to reevaluate. Okay? It was from 2110 was the first prolonged deceleration until 2132 when we delivered the baby. So that's a pretty good response. Okay? So she had an urgent C-section. She had a posterior tear in her uterus. It was a male infant that weighed 4 kilograms, bigger than we thought, right? And APGARs were 2, 5, and 7. I don't have a gas. Okay? We're in the home stretch, so let me just tell you. Let's go over. Yes. Why would there be a rupture posteriorly? That's a great question. It turns out that 2 things can happen that cause a uterine rupture with a previous cesarean section. It can be that the scar opens and go right through the scar. Sometimes the scar is so dense and thick that it doesn't stretch like the rest of the uterus. So imagine if you had a balloon where one part wasn't expanding and the back part was stretching. It puts all the pressure on the other side and it explodes there. So it's not uncommon to have a posterior, not uncommon to have it go up into the broad ligament, and the mechanism is that your lower uterine segment can't expand to accommodate the baby.
What's more likely?
It's more likely to go through this old scar.
Uterus just couldn't expand. It wasn't.
So, okay, let's go over our checklist. Did we have adequate tracing? Yes, we made sure that there were no missing artifacts. Putting on an FSC was a good idea here. Okay, we could look with an ultrasound or put a pulse ox on to make sure we're not checking mother. Did we establish situational awareness? Yes, we stopped and said, I think this thing is happening. I think we've got 15 or 30 minutes, depending on whether we get a prolonged decel or ongoing lates. But people are coming, and if they come and it's not better, we're going to section her. Okay? How long until delivery? She's remote. There's no way we're going to do a vaginal delivery. She's 6 centimeters. She's not going to make it. We need to be mobilizing the OR. Is there a risk for acidemia? Heck yes. She's got a prolonged deceleration, and I think she has a uterine rupture, right? So I'm setting my times. When that decel starts, you should say, aha, rule of 3s, right? First 3 minutes, 0 to 3, you're attempting resuscitation, identifying the problem, and calling the doctor. Repositioning, turning the pit off, putting oxygen on, giving terbutaline if you think that's going to help, okay? And you're calling for help. From minutes 3 to 6, the doctor should be there. You should continue to resuscitate. You should confirm the fetal heart rate with an ultrasound. And if it hasn't resolved by 6 minutes, you should be pulling everything out. Not the baby, the monitors and that kind of stuff, right? And moving to the operating room. In the next 3 minutes, from 6 to 9, we're moving to the operating room. We're reestablishing all the cords, getting everything set with her on the bed, so that and having anesthesia come, so that in the next minutes, 9 to 12, we can look and say, is the tracing still going? How does the tracing look? Is she stable? Do we need to dose with an epidural and section her? Can we do a delivery, or can we wait and watch? Right? This is evaluating the tracing and determining whether we need to do a C-section. By 12 minutes, we should be saying we've got to do a section. So from 12 to 15 minutes, we are putting her to sleep or dosing her, prepping her, and skin incision. And baby's out by 15 to 19 minutes afterwards. Right? So that's setting your situational awareness, giving yourself time points where you and goals, the things that you need to accomplish during that time point, during that time course. Did we confirm the pH? Well, the pH was 7.2, but there's something going on that's dramatic. This sudden onset of pain, especially shoulder pain, and prolonged bradycardia means you don't have an hour. You have 10 to 15 minutes probably, okay? The teaching points. Critical times on labor and delivery are the first hour and the last hour. Think about what needs to be accomplished during those hours. These are times when you have specific tasks that need to be accomplished, when you need to communicate well, and when you have to use your judgment. Okay? So these are when you're set, pay full attention to the first hour. Get everything set. And when you think, okay, we're about an hour away, reevaluate and get everything set for the descent and landing. Put the seat up, the trays should be back, belts tight and low, right? So initiate the last hour checklist when the patient becomes complete or when there's a sudden change. That's the end. Any questions? Okay. So, you know what? It doesn't happen like this on labor and delivery, right? I mean, part of the problem is this is just, I'm giving you cases that you know what's going to happen, right? But I do think that we just need to keep practicing the hard tracings. The case that we're doing, the small case, is not a clear one. It's one of those ones that doesn't fit nice into the little algorithm, right? You just have to keep looking at those tracings and talking about them, looking and talking at them. So that is the end of this, unless somebody else has something to say. All right, thank you.